Well, Alan Thicke, right? And Debbie Reynolds now in the news. But some of these other celebrity deaths have involved heart disease, at least preliminarily we know that. And Alan Thicke was one of them. Carrie Fisher was another. George Michael was another. It's put heart disease back in the spotlight as though it had never gone away, really. But it's shining brighter at the moment with question marks around some of these deaths. And really, heart disease has not gone away. And some of the terms we've been hearing lately have not used the word heart attack. So we thought we might try and understand some of the nomenclature here. And Dr. Michael Pack is with us from Bronson Advanced Cardiac Healthcare to talk about that. Good morning, Doctor.
Good morning.
Happy to have you with us today. Wish we were talking about something better than this, but this is information I think that everybody needs to hear, right? I mean, heart disease is still fairly prominent, isn't it?
Yes, of course. And in fact, this is just a reminder that heart disease will kill twice as many Americans every year than all cancers combined. So you're right, this has not gone away. It's just made more profile when someone of celebrity status has an event.
Do people gloss over it then? Because the way you phrase that, the statistics certainly are that heart disease is tremendously prominent. Maybe people don't realize that?
Of course, and that's what keeps us, unfortunately, in business. And we see it, and we're very busy because of it. And you're right, we've not perceived this ever going away. So it's just become more prominent in the public eye. But again, we see this every day.
Mm-hmm. It was interesting because with some of these recent high-profile deaths that involved some sort of heart issue, we didn't hear the words heart attack being used. We heard cardiac arrest and some other things. Do they really mean the same thing?
Not necessarily. Heart disease generally is just a very broad term that encompasses anything that goes wrong with the heart, of which it can be a variety of different things. It can be rhythm issues. It could be a weakness of the heart muscle. It could be coronary disease. So that's just a very broad term when we say heart disease. Mm. Heart attack is specifically a blockage in one or more of the coronary arteries that causes injury to the heart muscle itself.
All right, and we'll talk more about that in just a moment on WBCK with Dr. Michael Pack, Bronson Advanced Cardiac Healthcare, in just a minute. We're here with Dr. Michael Pack, Bronson Advanced Cardiac Healthcare. We're talking about heart disease. In light of this spate of celebrity deaths, some of them have had to do with heart issues, and so it seemed particularly timely to discuss this. Are there still predispositions to heart disease?
Well, of course. The main predisposition is the identifiable risk factors people have, such as diabetes, high blood pressure, uncontrolled cholesterol, or tobacco use, or finally inactivity. Those are the major predisposition issues.
Mm-hmm. When you think about certain people who suddenly have had issues with heart disease, maybe they've had a fatal heart issue, sometimes you say, man, we didn't see that coming. There are a contingent of heart attack cases, aren't there, that are something of a surprise.
That is true. There's something we call sudden cardiac death, in which people will have a sudden onset of acute chest discomfort, and that can lead to any rhythm issues that can cause sudden death. And that stresses the importance of early and quick defibrillation with AEDs that are now in schools and churches and gyms, and even on airplanes. Mm-hmm. And so if that should happen, that stresses the importance of early CPR and early defibrillation.
Yeah, and if you are in a place where that happens, are there people who know how to use those things?
Well, that would be the hope.
Yeah.
But unfortunately, a lot of people, one of the biggest barriers of even bystander CPR is just fear of doing the procedure, or sometimes fear of reprisals. But we encourage people to go ahead and just start doing chest compressions and then quickly get a defibrillator, of which truly we only have minutes to get those patches on somebody. They have automated the AEDs to the extent where you just put the patches on and it will shock someone into, by itself if it needs to be.
Wow. Okay. So it's become easier, essentially.
Correct. So people really don't have to have a working knowledge of how to do that. Just grab the AED, throw the patches on. It's clearly identified how to do that, and then just stand back.
So CPR, though, has changed in the last few years, hasn't it? The recommended way to carry it out.
Precisely. We used to think that respiration was really important. In fact, to do like 15 chest compressions or even 30 chest compressions with every respiration. We have found, though, that over the years, the respiration is less important than just doing chest compressions. In fact, it takes about a full minute of doing chest compressions to get the perfusion pressure up to the head enough to keep the brain going. And in fact, that's the only purpose of CPR, is to keep the blood flow going to the head until someone can be shocked.
Wow. Okay. And you still need to be trained to do that appropriately, don't you?
Yeah, it's worthwhile to undergo the training just so you're familiar about how to do the chest compressions. But certainly that is truly the most important part of it. If someone goes down immediately, there's still enough oxygen in the body, and every time you do a chest compression, you are still ventilating somebody. And in the past, one of the biggest barriers to anybody trying CPR is nobody wanted to breathe on someone else's mouth they didn't know.
Right.
And so that's why chest compressions are truly the most important thing, quickly and with a quick defibrillation.
When we talk about something like congestive heart failure, what does that mean?
That is also a very broad term that encompasses anybody that can congest. There are two reasons people have congestive heart failure. One is the heart muscle itself is weakened from a variety of different ways. The other is the heart, as we age, becomes a little stiff. And although the function is good, the stiffness of the heart also results in congestion. So there are two different varieties of what we term congestive heart failure. So again, that's a very global term, and any heart that just doesn't perform the same.
Mm-hmm. Can that be something that's gradual, congestive heart failure?
Yes, absolutely.
Mm-hmm.
And the truth, unfortunately, I think there are a lot of people out there that have even a weakened heart that just don't know it.
Mm-hmm.
And that can lead to things like sudden death, like what we talked about. Most people aren't out there running 5Ks or really pushing themselves. And so you're just doing your normal daily activities, and unless you challenge yourself, it's hard to know the difference.
Is there a way to be screened to try and determine that?
There are. If somebody is reporting, I can't breathe as well as I used to, I'm having a harder time climbing stairs, or certainly if they're more winded than they usually are expected to be, then it can be evaluated by both an EKG and an ultrasound of the heart.
We're talking with Dr. Michael Pack at Bronson Advanced Cardiac Healthcare. When we come back in a minute, we'll talk about some of the warning signs for heart attack and the notion that in the past those may not have been recognized as such, and we'll discuss that a little bit more in just a couple of minutes on WBCK. WBCK, a few more minutes now with Dr. Michael Pack at Bronson Advanced Cardiac Healthcare. We've heard discussed, Doctor, on a number of occasions, some of the clear signs that a heart attack may be happening, but let's hear those again.
If somebody, the hallmark of a coronary blood supply problem is exertional chest heaviness. For instance, lots of things can cause chest discomfort at various times. It can be reflux disease, chest wall pain, those sorts of issues. But certainly one of the most specific markers for a coronary blood supply problem, which is what everybody worries about, is exertional symptoms. So, for instance, if you try to walk or do things or climb stairs and you're feeling a heaviness in the chest, that tends to go away when you rest. That's really specific for a coronary blood supply problem. And then certainly that should be evaluated.
And if someone is feeling that heaviness, is that the only symptom they might experience?
No, everyone is so different, and when you're dealing with people, no one has to be textbook. So other symptoms such as increasing shortness of breath, again, with exertion, chest heaviness, sometimes it can be upper back discomfort. I've seen it even just arm discomfort. So everyone can be a little different, and certainly women can be more atypically presenting than men.
How so?
Women typically present later in the course of their coronary history. They typically have worse disease by the time they report symptoms. The vessels tend to be smaller, and they tend to present more atypically with symptoms that aren't quite as textbook.
So, in other words, their situation might be more dire by the time they're starting to notice this.
Precisely. And I tend to think women put off a lot before they actually report something. They're in the role of taking care of everybody else and sometimes forget to take care of themselves.
Yeah, the old societal norms playing into it here. You'd think, though, that men would fall into that, too. You know, we're supposed to be tough and handle pain, and there might be a notion to ignore something like that.
There are, and we've seen it both ways in both sexes. Just the data would suggest that women tend to delay the presentation and tend to kind of ignore symptoms a little bit longer than men do.
So heaviness in the chest could be a pain in the back, the upper back, or an arm pain. What's the best thing to do at that point?
If you have any of those concerning symptoms, then actually report it. Tell somebody, either your primary care physician, or if it's worse or bad enough, present to the emergency room. Then if you have those symptoms, what we do at that point is we do an EKG, blood work, those sorts of things. So if there's no evident injury at that time, then we further evaluate that with usually a stress test.
All right. And those can sometimes be scary, but it actually puts a person in a position of a bit of exertion, doesn't it?
It does. And we have various ways we can do stress tests if people can't walk very far due to orthopedic issues. We can chemically induce the stress if need be. And again, all stress tests that we do give us really good accuracy at determining if this is the heart or not causing the symptoms.
Are there any innovations in treating heart disease that you're encouraged about?
To a fair extent. The next holy grail of cardiology, if you will, is going to be trying to discern which of those plaques, which of those blockages in the coronary arteries that are just minor. Some of those blockages can pop open suddenly, and that's where people end up with that sudden death experience. We don't know or have a way yet of being able to determine which of those plaques are most vulnerable. So the next holy grail in cardiology is to sort of work on that and figure that out. We've come a long way in our ability to fix vessels with different stenting. We're on the several generations into our stents that we put in. Some of our newer stents are becoming bioabsorbable. So we're working a lot at that, and that's been our best technology so far.
Stents being devices that hold an artery open.
Correct.
And it used to be that you have to go in there and remove them?
No, every stent that we put in is just permanent.
I see.
But the stents provide an additional benefit such that it keeps the vessel open longer than just a balloon by itself. In the past, we used to balloon blockages open, but you had about a 30% chance of coming back within 6 months because they're re-narrowed. With the stents, that keeps that open, so hopefully you don't have to become a repeat customer.
Right. And bypasses are still being done, are they not?
They are. And if somebody has significant blockages in all of their coronary territories or even in the wrong spots where we cannot fix with stents, then bypasses are necessary, unfortunately, still.
Is angioplasty still being done?
Yeah, angioplasty is just the process of putting a balloon in and blowing that vessel up. So angioplasty is the first part of a stenting procedure.
I see. So it is still a part of the process.
Correct.
Boy, when you talk about somebody who needs a bypass and you talk about significant blockages, how is it that that person has not had a heart attack yet?
Because you can have blockages without damage to the heart. And what that causes is what we call angina. And that's the process of feeling the chest pain on exertion or shortness of breath with exertion. And that tends to progress until somebody reports it. And then when we evaluate it, there's been no injury to the heart, and the heart still looks great, although the vessels feeding the heart muscle just aren't adequate enough.
All right. So if we learn anything here, it is to pay attention to what you're feeling. And if you feel something that seems significantly like what's been described here, tell somebody or report it somehow quickly, right?
Correct.
All right. Well, we appreciate the update on all of this, and perhaps we'll stay in touch. Dr. Michael Pack is with Bronson Advanced Cardiac Healthcare, helping us sort out heart disease today. Thank you for your time.